Hello and welcome back to our new online series for controversies in rectal cancer. This collection of video content will allow us to explore those difficult decisions that our multidisciplinary team members sometimes have to make for these patients. You'll be able to watch renowned clinicians in the field give lectures on controversial topics, see our expert MDT panel explore challenging cases, and be able to enjoy some critical analysis and commentary. Each episode will have a common theme that runs through the broadcast. And in this episode, we'll be looking at the limits of treatment for metastatic disease. First up is Rees, a consultant hepatobiliary surgeon from Basingstoke in the UK, to tell us more about the limits of treatment in this field. I hope you enjoy watching.
Thank you for the privilege of being invited back to the Iceni Centre. And the topic I've been asked to define today: what are the limits for resecting colorectal liver metastases? These are my credentials, as it were. Over the last 32 years, we've resected nearly 3,000 patients with colorectal metastases. We've shown that it can be a safe operation. And in the last 10 years, we've shown that it can be a team product, so with now 4 surgeons and fellows operating with even better results than previously. Now, if I take you back 30 years, these were the guidelines that came out of a World Hepatobiliary meeting in Sweden, that we should only operate if there was only a solitary metastasis in one lobe of the liver, with a good margin, confined to the liver, preferably with a biopsy first. Well, we've shown that all these are absolutely ridiculous. The period of observation, preferably these days with chemotherapy, is still in vogue. Now, when we started, there weren't many people who actually believed those original guidelines, but the two on the right here, that's Bill Heald and Roger Motson, who kind of supported me when we started, against a lot of opposition, I might add. But, you know, you've only got to have one good idea in your life, and this was our one good idea, which came out of visiting Erlangen with Johannes Scheele and America at New Orleans. And we thought, well, if taking one out, why not 2 or 3 or 5? And if it works from one side of the lobe, why not take it from both sides? And this indeed has proved to be the case. One of the real objections I had in the early days was this concept of operating on people with bilobar metastases. We and others showed very early on, around the turn of the millennium, that actually if you have secondary metastases in the right and the left side of the liver, if you take them out, you'll do just as well as if it was unilobar. Now, I start with this slide. This is a paper we published a few years ago in the BJS with 3 consecutive 7-year periods showing an improved survival curve for each period. Now, you might argue that this may well be just stage migration effect with better scanning. Will Rogers wrote that seminal paper where he pointed out that when the Okies left Oklahoma to go to California, the mean IQ of both states increased. So, as we now recognize stage migration. But actually, the editor, James Garden of the BJS, pointed out something that we had missed in our paper, that in the last 7 years, that higher curve, we had operated on 9 times more people than in the first 7 years, with a 16% improved survival. So and what he didn't point out, that actually this was geographically about half the area in the third period as in the first period, because we'd lost Wales, we'd lost the peninsula, and so on. And people say, well, why is that? Well, in my view, we did 9 times more because of chemotherapy, converting inoperable cases to operable. We'll talk about that. But every study on chemotherapy in that era never showed an improved survival. So the improved survival for me was the improvement in radiology. We saw a sort of sea change in the 80s and 90s. People wrote a paper saying that, you know, the development of CT and MRI in the 90s was like allowing a blind man to see. So improved radiology means that if you have, say, 6 metastases and you find 6, then the likelihood you won't recur. If you only see 3 on a poor scan, then you can guarantee that you're going to recur. So I think radiology has come a long way and is still improving. So what are the limits? I've split it into 4 different sort of topics: the limits of anatomy, liver function, the biology of the tumours, and perhaps a word on the philosophy regarding this work. Now, I don't know why you all like the rectum. It's got an artery going in and a vein coming out. I mean, look at the liver. We've got portal venous structures. We've got biliary drainage. It's immensely complicated and difficult to work with. So the anatomical limits for us is if you have a huge lump in the liver involving things, or if you have distribution in both the right and the left, where the ideal operation would be a right hepatectomy followed by a left hepatectomy, these are the barriers that we had, or if you have key structures involved. So big lumps like this, we had to scratch our heads and invent new operations. This is an extended left hepatectomy. You can see there the sort of the left vein, the middle hepatic vein, the right portal, all dissected out. This was surgery evolving in front of our eyes, really. Distribution on both sides of the liver was the challenge that we had. And I put this slide in because I met this lady, this was from 22 years ago, and she came to me from the sort of palliative care team saying, look, you've got to do something. I've got young kids. And so we invented a new operation where we only left segments 5 and 8, the so-called Basingstoke Mohawk operation. And she came to see me at our patient day in August, and I looked at her and I thought, Debbie? And she said, yeah, Mohawk. And I said, oh, it's great to see you. She said, yes, I've brought my daughter and my granddaughter, and we'd like our photograph taken with you. And I must get that photograph because I'm very proud of it. So on this scan, it doesn't project very well, but trust me, there are about 10 metastases in this liver. And challenging as it may be, this is the sort of thing we do, the sort of so-called Swiss cheese effect on the left side. So this is the first stage where we've cleared the left side of the liver, and you can see down there we've actually ligated the right portal vein so that the future liver remnant of the left side will grow, and then we can go back in and do a right hepatectomy. So what do we call this? You've probably heard us use this term, parenchymal sparing surgery. This is where the action is. You know, when we started, we had 5 operations, you know, right hepatectomy, left hepatectomy. Now we have over 300 different permutations of bits of liver we've removed. This is all with parenchymal sparing. This is the challenge for laparoscopic liver. This is not about the technique. It's finding the damn things. It's having a knowledge of anatomy, and you need the radiology to be absolutely tip-top. So I haven't got time to go through all of this, but I'll just mention 1 or 2 things. So conversion chemotherapy, it's not new. Henri Bismuth wrote this in 1996, where he had inoperable cases, gave them chemo, and 16% became operable and they were operated on. Now, if this was a room full of liver surgeons, say 20 liver surgeons, I'd look around and there'd be 20 different versions of what is or isn't inoperable. But having said that, it's true to say that chemotherapy has completely revolutionized where we are, and that top curve is liver-only metastases, with chemotherapy now producing a response rate of 70%. And in the literature here from Folpet from Germany, showing that we had a 40% improved liver resection rate. I mean, and this is where we are in Basingstoke. And if you add that to the 10% who are operable anyway, so we're now beginning to take on over half the patients that are sent to us. So I think there'd be no discussion this would be unresectable. This was a young girl of 32, came from Bedford, came to see us, and after 3 months chemotherapy was improved, but after 3 more months, total of 6 months, this is what we had, and we operated. And she sent me a card only the other day. She's now over 10 years surviving, and actually has got a little girl, and how pleasing is that? She's free of disease. So what does all this mean? There's so much we don't understand. Now, just going down this list, the next line there, regional therapies. So regional intra-arterial irinotecan or Debiri, we use that a lot. Certex, intra-arterial radiation, which I'll talk about in a minute. Then we've got portal vein embolization to encourage growth of the other side, as I showed earlier. Staged liver resection. The so-called ALPS procedure, where we do the 2 above and transect the liver to encourage growth of the remaining liver. Combining surgery with ablation. We do all of those things. Finally, it's just liver transplantation. This is the new kid on the block. There was a paper I was listening to only last week from Oslo. The Norwegians have got a series of about 30 patients treated for colorectal metastases with liver transplantation. Fantastic 5-year results, unbelievable, but highly selected group. But I'm pleased to see that the liver transplant UK team are now looking at this in earnest. Our biggest problem, as you know, is its lack of organs. But I can think of 1 or 2 cases where they've got one lump involving all the structures, where this might be something that we might look at in very selected cases. The Oslo group, as a rule, had waited 18 months, 2 years before operating with a transplant to see what the biology of that tumor was going to turn out. So things for the future. Involving key structures, well, this is a constant headache for us, because look at all the things that could get involved. I show this because he actually rang me only 2 weeks ago and reminded me. He's 15 years on with that tumor, blocking the duct, as you see, and we need to do an extended right hepatectomy. And in the previous years, we'd have probably then skimmed the duct off the tumor, got a local recurrence for sure. So we were brave at the time. You can see how old this slide is, dividing the duct so you can see the entrance to segment 2 and then segment 3 duct, bringing a rule loop up. He's 15 years on, disease-free, and just shows you these aren't barriers. It was the mental barrier for us as surgeons to actually deliberately cut the duct. I think we'd all agree that's a pretty formidable challenge. And this sort of cases we used to do in the old day. And though the surgical challenge was rewarding, honest truth, these people did badly without chemotherapy as we now understand it. So surgical triumph, but they invariably had multiple lung mets within a year, so hardly a good way of doing things. Which brings us to liver function. Now, everybody knows that if you cut the liver, it regrows. You know, every patient I've ever seen will tell me this, and everybody's familiar and fond of the story of dear old Prometheus. Our problem is, I have forgotten what a liver, normal liver, looks like. Because actually, this is what the livers look like when they come to us. Because they've all had chemotherapy nowadays, and that we were worried about what would happen, liver insufficiency, infection, and so on. And we actually published the seminal paper on this in the British Journal of Cancer 12 years ago. And we showed that the people who'd come to us with more than 6 months of chemotherapy had a significant increase in life-threatening complications, surgical complications, and even mortality. That was the era before we learned how to deal with these people, before we knew about portal vein embolization and so on and so on. So we can handle them now, but it really did bite us initially because all the oncologists said, oh, it's no problem, you know, you can operate, it's fine. And these are the new words that we are now familiar with: steatosis, steatohepatitis, sinusoidal dilatation. I mean, I'd never heard of these words about 15 years ago. And we know that they affect what happens to you if you have a liver operation, including an increased mortality after irinotecan from steatohepatitis. The MD Anderson group showed this by looking out to 90 days, because it didn't show in the 30-day data. They only showed the increased mortality after the patients had gone home. So what is our problem? Our problem is we don't actually, until very recently, know how good a piece of liver is. So if you'd asked me 2 years ago, how much liver do you need behind after chemotherapy? It's very difficult, because we're doing some work on histology at the moment, and not everybody has the same reaction to chemotherapy. Some livers are fine. Then the next liver, which looks the same on a normal scan, is terrible. So we did some work recently with a company, a translational company in Oxford called Perspectum. We were given a grant by Innovatum UK for us in Edinburgh to look at this. And they have shown that using T1-weighted scans on MRI with extra sequences, which only take 10 minutes, but it allows them to measure steatosis, inflammation, fibrosis, iron content. And they can produce a picture that looks like this. So the green one, for us simple surgeons, is actually a good liver. I'll show you in a minute. The red one on the right is a terrible liver and will not tolerate much going on inside it. So we recruited 150 patients over 18 months, And we're in the process of writing this paper now, and I haven't got all the data yet, but I can tell you that both Edinburgh and us are very excited about this. I think this will be probably the best bit of work that we've ever published. And to give you an example, we were blinded, unfortunately, during the study as to what the scans were. So we've only been able to see these scans in retrospect, looking back as to what happened. So this young lady, well, 64, she needed an extended right. And then the segment 2-3 was about 30% residual volume. I'm going, I was awake the night before thinking, is this sensible? Will this work? Do I need to do portal vein embolization? Well, she never turned a hair. She was home in day 4. When we look back on the scan, her liver was green. If I'd known that, I wouldn't have had to lose sleep or worry about it. Another case, completely opposite. The ideal operation for this chap with a big tumor involving the right hepatic vein, needing a right hepatectomy. When I got in there, I thought, oh dear, this liver really doesn't look good. It's what we call the blue liver. So I actually did a technically very difficult operation of segments 6 and 7, skimming the middle vein and so on. And thank God I did, because actually the liver was terrible. And if we'd calculated the future liver remnant after right hepatectomy, we'd have been down in the low 20s from the function of that liver. So thank God I didn't, is all I can say. But that's how people end up going into liver failure, because you can't, on the normal MRI, that looked the same as any other case. The early results show that, yeah, we can correlate liver function with this weighted MRI score. And this is the goal. This is where we want to get to. So if you can imagine there's a patient needing a right hepatectomy. He's got a small left lobe, as usual. It's not a 50-50 split usually. So the future liver remnant is 35%. That's fine. We can live with that. What this new technology will show you will actually work out the health of that remaining liver and actually calculate an adjusted score depending on whether it's red or green or whatever. So in that case I just showed you, the future liver remnant of 35% goes down to 20%. And we know you can't operate and expect a swift, easy ride afterwards. So we go to tumor biology, and first a word of warning. I am no molecular biologist, but I'm interested because as a surgeon, I need to keep abreast of what's going on. Nothing new here. Marty Hudson, my hero, wrote this 30 years ago. Biological determinants so often transcend technical and anatomical ingenuity. I used to use this slide up until about 10 years ago against dear old Marty, who I absolutely adore, in saying, Marty, you have no idea how we've improved, what things we can do now. But we've reached that point where actually we've now got to fight the biology. And this is the bit that we are now struggling with. So this paper in Nature Medicine in 2015, they looked at the molecular subtypes, and they've grouped 4 different types of behavior for tumors. So there's a lot of work going on out there. Has it translated yet to clinical practice? No. But actually, we are looking at this with others from Southampton and Oxford to see whether in our work we can actually ratify this work and where could that lead us. Now, I was asked to comment on any differences between the colon and the rectum. Well, when we first published the outcome of liver resection in the mid-90s, one of the most weird findings was that people with a right-sided tumor did really much worse than the others. And if I'm honest, we didn't include it because I thought this is a bit weird. There's a glitch here. So we actually dismissed it. But now people are getting very excited about the different molecular biology between left-sided tumors and the right-sided tumors, and look at all those BRAFs stuck in there on the right side. People are making a whole research based on these differences, and frankly, your rectum should do better than somebody with a right-sided tumor. Now, does this matter in practice? Well, it does from some data recently published in the Lancet Oncology with the first author, Harpreet Wassan, one of our premier UK oncologists, where they looked at the randomized phase 3 trials, 3 multi-center, Foxfar, Surflox, and Foxfar Global. They thought, if we get all this data, we will show how adding SIRT or SIR spheres to FOLFOX or oxaliplatin 5-FU chemotherapy should improve the outcome. So we're all very excited about that, except it turned into a negative result, apart from one thing. People with a right-sided located tumor did so much better with adding in SIRT. So NICE has now commissioned 10 centers to look at this in more detail, because instinctively one can't help feeling SIR spheres must have a role in here. Of course, it's us that doesn't recognize that role as yet, but more to come on that one, I'm sure. So we end up with your philosophy about this whole topic. Yeah, we've got more people now on our side for sure, but I still meet people, both patients, doctors, nurses, who will still say, look, this is a ridiculous idea. They've got secondary disease. What on earth are you going to operate on them for? So, you know, a lot of people would spend a lot of time convincing. And certainly back in the day, going back 10 years or so, one of the problems was people still think liver surgery is a terrible thing to do to somebody. They imagine this massive blood loss that we all experienced when we were training. Well, it's not like that. So to try and put this straight, we teamed up with Professor Jane Blaseby from Bristol, who is the sort of, you know, who is the master of quality of life studies. She is the person. So we joined forces and we put 250 patients who came to Basingstoke through a prospective study. And actually, unlike most major operations, we show that apart from a slight dip in quality of life at 3 months, at 6 months and 12 months, they return to normal quality of life. You can't show that for most major surgery, I can tell you. And even more, we took the first 100 people to survive 5 years and repeated the study and compared to what they started out with. And basically, they were no different apart from one major change, and that was the fact that at 5 years, the high anxiety rate was statistically much less. In other words, they return to normal life and get on with it. So hopefully that will convince a few more believers, if only they read the journals. So there's another big philosophical issue is what about people with extra-hepatic disease? We need to look up our data and update it, because I would say of the people who have survived 10 years, the majority have had either a lung resection or ablation and a second liver resection. And we just need to show that to people. It's not new. On the continent, Dominique Elias in France showed years ago that actually resecting extra-hepatic disease does work. But we're currently looking, as you know, closely at the combination of liver and peritoneal malignancy. And so this is work that we need to update, maybe an excuse to invite me back another time. Now, this is the limit for me. I'm sorry there's a blank slide here. I was actually trying to find a picture of a nasty pelvic recurrence, but you know, in Basingstoke it's very difficult to find these things. But basically, if you can't control the rectal primary, then we should not be doing anything to the liver. There would be nothing worse than clearing the liver to allow somebody to die with local recurrence in the pelvis. So I think that is absolute limit as far as I'm concerned, always has been and always will be until we find something new. Now, the other philosophical limit for a colorectal surgeon is this concept of doing the liver before you do your anterior resection. I know this troubles colorectal surgeons hugely, and I thought we'd just put it in context for you as to where is the place of a liver-first approach. This paper we published in the British Journal of Surgery in 2016 was, at the time, the biggest single-center series of liver-first in the world. And of the 1,000-plus patients in that era, only 17%, or just shy of 100 patients, had actually undergone a liver-first. So we don't do it on everybody. Others around the world do it on everybody. But we select patients for particular reasons, usually that they were inoperable and converted to operability. But there is this little group with rectal primaries who require radiotherapy, where in that time span from recovering from the radiotherapy, we can nip in and do the liver resection because, frankly, they recover a lot quicker from a liver than if they recover from an anterior resection. So I think there's an opportunity there that we need to exploit. So in this series, only 20%, but I think that is an area where we could probably expand it more. Just to show that, the disease-free survival, the liver first, didn't seem to do as well, but that's because they're such a bad group. When we corrected that for the Basingstoke Predictive Index, which we've talked about before, then actually they did just the same. And when you go to Switzerland, where in some units they actually do everybody liver first, they've shown there's no detriment to that. In other words, this concept that the primary will still be firing off cells is not borne out in practice, because of course they all have had chemotherapy in a neoadjuvant setting. So I finished with this slide, which I used, 25 years ago. Robert Louis Stevenson, of course, ended up in Western Samoa, where he's revered as a storyteller. And he wrote many years ago, it's better to travel hopefully than arrive. And I think for all our patients, this is a tough business. And all we can guarantee is that we'll do our best and we'll be honest with them. But actually offering hope along the way is actually very important. And dare I suggest that for the rugby supporters for England and Wales, we're travelling perhaps a little bit more hopefully at the moment than we have in the past. So who knows? Thank you.
What a fantastic lecture that was. And we'll be discussing that in more detail later on in the programme. But for now, let's look at one of our complex MDT cases that was discussed earlier in the day. Hello and welcome to the Iceni Centre's Rectal Cancer Multidisciplinary Team meeting. My name is Greg Wynn. I'm one of the consultant colorectal surgeons here in Colchester in the UK, and I'm delighted to be able to invite here today an expert panel from around the country to discuss these difficult cases. Before we start, I'd like to get them to introduce themselves to you.
I'm Myrddin, a colorectal consultant from Edinburgh.
Hello, my name's SIBTAIN. I'm a clinical oncologist. I work at St Bartholomew's Hospital in London.
I'm Rees. I'm a hepatobiliary surgeon with a special interest in colorectal metastases in the liver.
I'm Ian Daniels. I'm a colorectal surgeon from Exeter.
I'm Anna Wordley. I'm clinical nurse specialist for colorectal cancer at Colchester Hospital.
Hello, I'm Tan ARULAMPALAM. I'm a colorectal surgeon in Colchester.
My name's HUGO Ford. I'm a medical oncologist from Addenbrookes Hospital in Cambridge.
NAJIB HABOUBI pathologist, GI pathologist in Manchester, UK.
Thank you. And without further ado, we'll get on with the first case. This is a 78-year-old gentleman with a BMI of 26. He has come off the bowel cancer screening programme, so he is asymptomatic. He's got a past medical history of hypertension, depression and prostatic enlargement. Digital examination was normal and colonoscopy shows an impassable biopsy-proven adenocarcinoma in the upper rectum. He's had a CT colonography which was normal, showing no proximal lesion. There are the endoscopic pictures, and Bruce, we've got some staging to look at, I believe.
Yeah, so we've got the MRI, first of all, showing the lesion here of the upper rectum. And as you can see from the axial images, this is a T2 lesion, no evidence to suggest nodal spread or extramural vascular invasion. So T2, N0, V0, and if I just show you the staging CT that goes with that. What we have here is, as you can see, there is a solitary, well, apparently solitary lesion within the liver, which is concerning for a metastasis. The other observations here is that there's quite a small volume left lobe. The venous anatomy is normal, but if I just show you the corresponding arterial images, there is a replaced right hepatic artery which comes off, you can see here. The only other abnormality to note on the CT is that there is an abdominal aortic aneurysm arising below the level of the renal arteries. I'll just show you the coronal images of this, just to show you the relationships of that liver lesion. Oh, sorry, wrong step. Which shows that that liver lesion is very close to the hepatic vein there. So, so the stage is T2, N0, EMVI 0, M1 probably. At this stage, we would normally routinely go for a liver MRI. Two reasons, really, one of which is to confirm what we think is there, and the other one is to find the stuff that we don't know is there, so that before any treatment happens, we know the true extent of liver disease, because CT will underestimate the volume of disease that is there.
Okay. Presumably you all agree with that. Merv, how much better is a liver MRI than a liver CT?
Well, we looked at this formally a few years back, and 60% of the people who came with a CT scan, MRI demonstrated extra lesions. And a European-wide study showed that MRI with gadolinium is better than CT, but actually MRI with liver-specific contrast, Primavist, is better still.
Okay, thank you. Okay, Bruce.
So for my money, people always argue, well, that's expensive, but for my money, just get that one scan in at the beginning to see where you start from.
Yeah.
So should we have a look at the liver MRI, Bruce, please?
Yes, so the liver MR, which has been done with tissue-specific agent, shows that this is a solitary lesion, and it has the other, I won't show you all the sequences, but it is consistent with a solitary liver metastasis.
Good, okay. So presumably we would get our tertiary liver centre involved at this stage and ask their opinion, get them involved at an early stage. So, Merv, can we have your thoughts on
So would you perhaps think about a vascular opinion as well for that aneurysm?
How big is that aneurysm?
I think it was about 4.5 centimetres.
Okay. 4.5 centimetres. Okay, he's been referred to the vascular surgeons and they put him on a surveillance protocol.
If you do a PET scan as well to rule out any extra-hepatic disease.
Merv, perhaps you'd like to comment
You do
on
that routinely?
Okay, I blow hot and cold on PET scanning.
Yeah.
I've been there, done them on everybody, been there, done them on nobody.
Yeah.
I think that if you have a straightforward situation, I think our peritoneal radiologists now are so amazing with CT within the abdomen. I don't see what they see, but they tell me what's there. And I think PET scan, you do get false positives. I've been bumped a few times, and you go in and it's a little, particularly after colorectal surgery, you get little collections and things. So I think if it's a straightforward primary problem and a straightforward liver with MRI, I don't find PET scan that helpful. Because it depends whether your philosophy, are you looking for ways where you never do anything, or are you looking how you can do something? On the other hand, if you've got heavy nodal involvement with a primary, or a really complex liver situation that is going to push you out to the boundaries, then I think a PET scan is helpful, because with nodes, you need to know how many nodes there are, and that will be a game changer. If you're going to do something fancy to the liver, you better be clear there is only liver disease to worry about.
And this is quite low volume disease, just a T2
Yes.
and a solitary
Yeah, so I don't find PET scanning that helpful here, in this particular case.
Yes. Okay, so what is going to be the management plan for the patient?
It never ceases to amaze me. You've only got one little nodule, but it's sitting in a very awkward place, because you can't reliably do a wedge excision for that. You almost certainly get a positive margin. And you've got a quite big primary, or is it T2, you say?
T2
not
is
obstructed.
Yeah,
He's 78, so I'd like to hear from the oncologist as to what's he going to be like with a bit of neoadjuvant chemotherapy. Or from a technical point of view, if the oncologist said, well, look, I don't think this guy is going to do well with chemotherapy in terms of tolerance, I'd worry that that one small lesion, if it grew, could become a big problem. And it's, at the moment, a relatively straightforward, say, posterior sectionectomy, just taking 6-7 on the vein. I'd probably be keen on that if the oncologist said, I don't think we'll get very far.
So the primary is at an early stage. So you're looking at a liver first approach or neoadjuvant chemotherapy?
I wouldn't go for rectal surgery first. I think if we could go for neoadjuvant chemotherapy, I think that would be quite helpful.
Okay.
I think it's impossible, though, isn't it? It's impossible. Is that right?
It is.
Yeah.
We're not
So
clear
we
whether
need to
that
sort of-
is due to technical problems or due to the tumour. It's not clear from the report. The patient remains relatively asymptomatic.
Okay.
Okay.
So I'm not hugely enthusiastic about chemotherapy, but he's got it anyway. But I
agree.
In this case, I think my thought would be he's a relatively low risk patient, and he's got a solitary metastasis. He looks like he's got a relatively, obviously it's not that good because it's spread to the liver, but a relatively favourable primary tumour. And there's always a risk in somebody of 78 that you could do more harm than good with chemotherapy. So I wouldn't be over enthusiastic about chemotherapy, but it's a perfectly reasonable approach to do.
So what do you give if you want to give chemotherapy?
I'd ask Merv to operate on his liver. If I was going to give chemotherapy, so I'd plan for a few.
That's really interesting, and I'm really pleased you just said that, because there is a very strong oncological view in the UK that everybody has to have neoadjuvant chemotherapy in operable situations, even though the Folfox study showed no benefit at 5 years. In operable cases, but I would, hasten to add, that's still the minority. There aren't that many easily operable cases up front that we see.
Exactly.
But when we do see them, you can tell I'm browbeaten because I'm sort of giving in. Okay, you want to give a bit of chemotherapy, go ahead. But
I agree. It's his age that puts me off giving chemo first. We'll make him less fit for surgery. Will affect the quality of the liver. The thing that's going to cure him is good surgery.
Yeah. Are we focusing on his age as opposed to his function?
Well,
he's got peripheral vascular disease. Clearly, he's not
AAA.
Yeah. Even so, you can turn a 78-year-old into 88 with 3 months of chemo.
Okay, so he proceeds through his 3 months of neoadjuvant chemotherapy without complication, and presumably he'd want some scans after that to see what the response is. So, Bruce, let's have a look at those.
So I'm showing you the CT first, which shows that the liver lesion, this was pre-treatment, is now looking like that. So good, there's a partial response. And the rectal abnormality so pre-treatment it was T2, this thing here, and now rather difficult to see. So pessimistically a 2, possibly a 1 TRG, but certainly, pessimistically T2 N0, EMVI 0, and treatment response, partial response to metastasis as well as the primary.
You've got some endoscopic views?
No. No, we haven't.
Did he have an endoscopy?
I don't think he did.
So,
but obviously an excellent response in both the primary and the secondary. So,
I mean,
Merv, are you still, you don't want to go liver first now, do you?
Well, there's not much going on in the liver. And these are difficult decisions now because there's hardly anything there. You can't, even ablation is sitting right on the vein. They're the ones that tend to recur. But I'm quite relaxed about somebody taking his rectum out.
If he needs his rectum out, I'd want to scope him now.
Yes.
Okay. he went for surgery on his primary. He had an uncomplicated anterior resection. NAJIB, can we just have the pathology of that, please?
I don't seem to have the pathology of
We
that.
don't have it, okay. It showed a T2N0, clear margins.
Right. I'm just
So-
looking, I don't seem to have it.
There was some residual disease there, despite the fact they didn't have an endoscopic assessment. Okay, so he's 3 months after his anterior resection now. He's reasonably well. We thought we'd better get some more imaging of at least the liver to see what's happening. So he's had a CT and a liver MRI. Rees.
So, two CTs I'm showing you. This is the one that showed the partial response with that small lesion there. And this is the most up-to-date CT, which has shown that it's now going the wrong way. Liver MRI confirms that it remains a single lesion.
Sorry, can I just ask, did he get some chemotherapy following the surgery? I wasn't clear. It didn't, no.
No.
Okay.
He was without treatment.
Okay.
Okay.
Would you want some chemotherapy after surgery?
No, I just wondered.
Get the surgeon in.
Yeah, correct.
If possible.
I love these boys. They're all for surgery. I love it. I think I'd probably want to know that the aortic aneurysm hasn't expanded. Just
It hasn't.
Fine.
Good point.
Just the growth in the solitary liver metastasis.
And the liver MRI, Bruce?
Doesn't shows similar abnormality in the sense that it demonstrates tumour progression, metastatic progression, but remains a solitary lesion.
Remains solitary. Okay. So, Merv, what do you want to
Well, I think, I mean, it shows that, you know, in the old days we used to do trial of time in elderly people. He's got vascular disease. I presume he's not that fit, but a bit of trial of time just to make sure there's nothing much developing is quite helpful. In the modern world, it's virtually impossible to do a trial of time without chemo. But he has actually had a successful trial of time with chemo. He is a chemo responder, and we know these people will ultimately be in a better group. I mean, his left lobe looks a bit small, but I think I'd want some back on the coronal vis. I think we could get away with a posterior sectionectomy. I'd probably want to look at even just steatosis on the MRI in the in and out phase. Is it a fatty liver or not? He's 78. If the liver isn't very fatty and he's otherwise well, I probably could go ahead. If the liver was very fatty, it's a small left lobe, I might look for a portal vein embolization.
There's not much hepatic steatosis that we can see on.
Okay, so if it's, you know, because even that measurement of steatosis is quite helpful.
Could I add in something?
Yes.
Is that if there was any big risk for surgery, that's a very good candidate. He's a very good candidate for stereotactic radiotherapy. It's a solitary lesion. It's next to a vessel which reduces the effects of radiofrequency ablation because of the heat sink effect. And this is exactly the sort of patient who's a bit older, has an aneurysm, may have been on anticoagulants. I know he sailed through his anterior resection, but stereotactic radiotherapy using either a Linac platform or the side knife would work quite well for him.
Okay.
He's a good prognosis patient. We could avoid big surgery.
So he wants to know whether that would be curative.
It would be curative.
Okay. With the same results as surgery?
So we haven't got head-to-head comparisons as yet, but it's small. We can get a really good dose into that. It's in the middle of the liver. There's no dose compromise because it's a good distance away from the hilum and other bowel structures. So we could easily get 60 gray into that. And I'd expect really good local control rates.
The other possibility would be microwave ablation as well, rather than radiofrequency ablation.
Yeah.
Because despite his...
the alternate is IRE. I think microwave ablation I would not favour because I think the local recurrence when they're next to the vein is...
Even with microwave?
Yes.
Okay.
But IRE, which is coming in, looking for a place, would probably rival your stereotactic radiotherapy.
Yeah.
And I think that I'm not against that idea. But the last series was presented, I mean, you've still got very small numbers.
Yes.
But it's evolving, and I think, like all these things that are evolving, I wouldn't become what I am by not listening. So I'm certainly not against that concept.
Yeah.
Particularly in this particular individual, as things evolve. It's 2015. I don't think you were offering it back then.
Oh no, 10 years we've been going. No.
So where's
possibly.
the data?
Well,
Where is the data?
Well, because there's so many...
Maria Hawkin produced some data, but they were quite small numbers.
It's still small number because there are so
and there
many...
were recurrences, even from small things.
Certainly.
So it wasn't, the recurrence from surgery is
surgery
zero.
Surgery is the best treatment.
It's zero.
Absolutely. But if the risks of surgery outweigh the potential benefits, then I think it's a very good second choice.
In a 78-year-old with a vascular disease, this might have been that
Yes.
patient.
Well, this gentleman's performance status is zero. He's not got that many comorbidities. He's still in a part-time job. He's enjoying his life. He wants a cure. So, the liver surgeon involved obviously was worried about that size of that left lobe. He had a right portal vein embolisation.
So I've been sitting here worrying about it. The trouble is, we're in the armchair today, aren't we?
Yeah.
And it's very interesting. When you're in the armchair, you become very relaxed.
Cavalier.
But probably if you were saying, you've now got this patient, you've met him, and I'd probably go, oh, actually, that left side is very small.
What Bill Heald describes the reckless courage of the non-competent.
Yeah.
Okay, so we've got some scans after embolisation, I think.
Yeah, so I'm showing you two CTs from that date. One on the right precedes the embolisation, showing that metastasis, and you can see the metastasis itself has grown. This is the embolic material within the right branch of the portal vein. And we can see that there has been some growth of the
Not massive.
Left lobe, but it's still quite a small left lobe. And what we don't know also is without the help of anything else, is how steatotic or how poor quality that left lobe is from the imaging that we've got here.
Bruce, what's the time period again between those?
They are, the CT on the right is October, and I think the next one is January, so 4 months.
Okay. So weight and...
So he's not grown a lot. You don't need to grow a lot, interestingly. You don't always see this massive, huge left lobe because, of course, it's in 3D. So if you do measure transverse diameters, you may get a centimetre more. So I haven't seen the measurements, but a centimetre is quite a big volume increase. The increase in the lump during that time is worrying, and I think in a fitter patient we'd have probably kept chemotherapy going while that was going on now. In a 78-year-old, probably no.
With the retrospective, we must be wondering why we didn't do the posterior sectorectomy when we started.
Exactly.
Yeah, surgery.
Yes, exactly. But I think, that's the good thing about reviewing cases and learning. Yeah.
So surgery now?
I haven't seen the exact measurements, but I don't see why not.
But when you're happy, okay. So he's had his liver resection after his embolisation, clear margins, and subsequent surveillance, imaging and follow-up is all clear. He's now 30 months after his initial diagnosis, and that aneurysm has grown slightly. He's now with the vascular surgeons, and they want to do an aneurysm repair on this chap. They want to know what the prognosis of this chap is before they make a decision on his aneurysm repair. Who's going to answer that question?
I'd tell them he's cured.
I mean,
if he needs an AAA repair, that's what's going to kill him before any recurrence.
He's
considering
more than
an
2
EVA.
years out.
Yeah.
Which has a much lower mortality rate to it.
No, absolutely.
So the natural history of his aortic aneurysm is now worse than the natural history of his outcome and survival curve for his colorectal cancer.
And you're more than 2 years out from diagnosis.
He's got a very good chance of living 10 years from his colorectal cancer point of view, i.e. effectively cured, if not actually.
So ignore his cancer, get on with the aneurysm.
Yes.
Yes.
Yeah. Okay, so he's had an endovascular endoscope there.
Why don't you say we're sitting in the armchair? I'm really nervous. Before every scan comes up, oh no, what have we done? What have we done?
So Bruce, he's now got a routine surveillance CT scan at 3 years after diagnosis.
So that's this one, and you can see that he's had his liver surgery. He's got excellent hypertrophy of the residual liver. But if we come back up, there is now this ill-defined mixed density nodule within the right upper lobe, and there are potentially some other little nodules around that are new. I spotted one just as I went past. Anyway, we reached a stage where there's a little mixed density nodule there, which is tiny. But neither of those things were there on the previous scanning. So the concern is that that thing there represents potentially a metastasis. And if we were on the imaging point of view, we'd be looking for the secondary signs to suggest that this patient actually was growing some tumour. So we'd be asking what the CEA was if it had been done. And then we would equivocate, and we would either offer an interval CT, or we would go for a PET scan to see if it was metabolically active, recognising that that is at the lower limits of what we might see.
Worth a PET now?
I think that's a bit small to rely on a PET. It might well be negative, and it's still a secondary. It looks just under a centimetre, is it?
Something like that. So it's right at the limits of what you would expect.
Yeah.
So he's now 80 years old, isn't he? How old is he now?
84.
81. 81, yeah. 81 years old. So we've got to reassess him in terms of what his performance and everything is like at this age in order to take this any further.
Almost better than he was 3 years ago.
Better he hasn't got cancer.
Yeah.
And no abdominal.
And no aneurysm.
Look, this is obviously very worrying for small volume metastatic disease, but it is small volume, and I think we would certainly just watch that for a bit, interval CT scan, see what evolves.
All in agreement with that?
Mm-hmm. Trial of time?
Trial of time. Okay, we went for a PET CT. So we're starting to think about a tertiary lung referral.
So the PET, which is 3 months after the previous CT, so trial of time and new imaging modality, which in itself isn't necessarily that helpful because you want to compare like with like. You do get axial imaging with your PET CT, so pulmonary nodules you can compare. But anything else that requires enhancement to compare like with like, you can't. This is the PET scan. I'm showing you selected images. The activity on the workstation suggested that was active, and there's a node in the subcarinal region. That's the other thing to notice, that the images that we see on PACS aren't the whole story. So they need to be looked at a dedicated workstation where they can be interrogated properly. So it looks all right to me on a PACS workstation is not the whole story. So we always need to bear that in mind. But it shows that was a positive node.
Okay, so the report I think showed right upper lobe avid lesions, and no extrapulmonary disease and no other worrying disease. So,
but the subcarinal node?
I haven't seen the report, so I don't know what they said.
So the report
and again, that's
worried
what
about
you need
that.
to know, because you can have a tumour-like response where the standard uptake value doesn't reach the significance that you would think, and that may well be in the case. But if the activity was sufficient within such a small lesion, then with a much greater degree of confidence you would call the pulmonary abnormality, which is, I guess, what they have done.
So making the assumption that this disease is confined to the right upper lobe, as far as we know.
He's a smoker, presumably.
Ex-smoker.
I wasn't clear. Did you say one lesion on the PET scan? Or did you say lesions?
If there are more than one, they're close together.
Okay. So on the original CT, they were all unilobular. Those no, okay. And the CEA, do we know if that's gone up? Was he a secretor?
Borderline raised.
I don't know, I would get a lung opinion on it, but I'm tempted, all other things being equal, just to sit and watch if we're assuming this is metastatic disease. Hugo's intimated that this might be a lung cancer, so a new lung cancer, maybe worth getting some sort of tissue from that 1 centimetre-ish lesion to see where we are.
Ian, should we just be sitting tight on this without getting a tertiary centre involved?
I think it would be very difficult now not to ask for a secondary opinion, given, you know, we've got a man who, as you say, his health is still good despite his age, and we've put him through all these things over the course of time. We have to, we're you know, there's duty of care to ask for an opinion on a specialist area.
Okay.
I think, you know, for me, this, I mean, is a man who could perfectly well have a small primary lung cancer. He's an ex-smoker. He's 3 or 4 years out of his bowel cancer. Certainly it could be, you know, location-wise, of course, it would be a good place for bowel cancer secondary, but it could equally be a small primary lung cancer. And I wouldn't sit on this if we thought that this was just a solitary lesion and we've had a trial of time and we haven't seen any more. I would be referring it to a lung MDT. If he's fit, that would be very easy for them just to wedge out for an excision biopsy. Looking at that, I think there is some uptake in the subcarinal nodes, and we'd probably go for a EBUS, a US biopsy of the subcarinal nodes, but I wouldn't sit on it myself.
Okay, so he is referred to the tertiary lung centre. They've looked at the scans, they've looked at him, they've agreed to a lung resection, and he's had a right thoracotomy with 3 metastatic deposits removed, one which turns out to be a lymph node that's heavily involved with malignancy. It is consistent with colorectal origin.
I think if you do the immunohistochemistry, presumably it's going to tell you whether this is primary or secondary. So I think I'm sure they proved that. Now this is positive for CK20, which is specific almost to the colon.
He's now had some further chemotherapy. Just describe where you give the chemotherapy and why you give it, and in what order, in this person who's had 2 metachronous metastatic deposits in separate organs. What's the approach?
I must admit I'm not convinced I would have offered him chemotherapy. I think the justification for doing so is he's got, you know, clearly multiple small metastases, he's got nodal involvement. Some stage he's going to progress, but for my mind this has progressed over 3 years, and the biggest lesion was less than 1 centimetre in size in an 81-year-old. So the natural rhythm of his disease is quite likely he'd go for another 3 years without needing any chemotherapy anyway. So I would have had a discussion with him about the risks and benefits of chemotherapy in that situation. Having said that, you know, if you're going to do it, what would you give? You know he's sensitive to the chemotherapy he had preoperatively. So I'd probably give him some, and he got on with it well, so I'd give him some more of whatever that was.
Is it inevitable that he's going to get a recurrence at some point in the future?
Well, it's not inevitable, but it is likely.
How likely?
Well, so the data would suggest that if you've managed to achieve a complete clearance of all the disease that he's got, then he's got, as with liver metastases, he's got a very good chance of a 5-year survival. He's got 30+% 5-year survival. I'm worried because I think he's got a subcarinal node, and I bet they haven't taken that out. So I would say I think he's going to recur. He's going to recur somewhere in the nodes, if not further lung metastases. But that's just my instinct about this case.
Well, what's your opinion on people who've had 1 liver resection and they've got another metachronous deposit somewhere else, or even an extra-hepatic metastatic disease?
Well, you know, they return to their previous curve. As long as you, if you take, say, take a solitary liver met out, and then you have a survival curve that's 50% at 5 years. If you then get a lung met and you take that out, you return to that same curve. So one would be reasonably optimistic at this stage. Of course, the pessimist would say, oh, he's got a 50% chance of recurring by 5 years.
Okay. So he's had some further surveillance imaging. He's now 18 months down the line from this.
He's coming up to 5 years?
From his liver operation.
He's 4.5 years after diagnosis now. So we've got a CT and a PET CT.
So the CT shows post-surgical changes on the right following the wedge resections, so it wasn't a pneumonectomy. And it also demonstrates a new lesion within the left lung there. And in addition to which, just show you one of those, that subcarinal node looks a bit bigger. And also the left adrenal, which was previously normal, is now significantly enlarged. And the PET scan confirms those findings. It demonstrates that there's metabolic activity in the subcarinal node, that thing in the lung there is positive, and so is the adrenal, but doesn't demonstrate anything else.
But that's unusual for colorectal to go to the adrenal, isn't it? It's more common with the lung, which we have excluded.
Well, I think we're seeing more of it because we're being more aggressive, and so the pattern of how the disease is behaving.
Well, I follow patients to the post-mortem room, and I don't see that.
Okay, that trumps psychology. Fair enough.
But I would agree we are seeing different patterns of recurrence. The more you do, you know, like lymph glands in the axilla, who had ever thought of that from colorectal mets? But if you push them out to 6 years, you get funny things happening.
And brain metastases.
And brain metastases.
In fairness, the profile has changed significantly.
Since I retired, you mean?
So,
Bruce, just looking at that subcarinal node, on the first PET scan before he went through the operation, this node looks precarinal rather than subcarinal. Do you think they're different nodes?
It's probably the same node.
It's like the same.
So that's
Yeah.
and then the other PET you showed.
It's the same.
Same.
Is it the same? No, I think.
Yes.
No, I think that's subcarinal, and that's. So that scan on the right.
I mean, it's very difficult. That's the carina there, and then going up and then coming down. Wow.
It's not the same.
I don't
You're
know.
seeing it.
Bit of misregistration.
Yeah.
It's a different node.
Yeah.
Okay,
It's certainly similar.
Yeah.
I think
And maybe there's been architectural distortion because of the lung surgery. Who knows? I mean, I'll take your point, but we don't know what was resected.
Okay, so clearly palliative now. When would you start palliative chemotherapy?
he's 85 now. I'm not rushing to give him chemotherapy.
Leave him alone.
Well, I'm not
Treat
rushing
the
to give him chemotherapy. He's got no disease that's going to cause many symptoms. It's growing at a rate of, a few millimetres a year. He's 85. Enjoy the golf.
Absolutely. If he plays golf.
If he plays golf.
He could learn.
maybe he plays football, you know.
Yes.
Anna, how do these patients feel when they've been through such a long journey and they fail at the end of it? Is it that they've been through a whole load of treatment and it's all been futile, or do they feel very grateful that they've had extended quality of life?
I think when you start off with surveillance for patients immediately after, their original bowel cancer resection, they're very hopeful that that will be the beginning and end of the problem. I think for these patients that have serial recurrence or secondary disease, rather, they start to think that will always be so, that you will always be able to do something curative. And I think managing that, with this particular patient, who comes with sort of all of his family, and they always want, you know, obviously whatever can be offered, and that's why we asked, you know, the tertiary centres for their opinions, and they took them on. And it was the same with having conversation with him about exactly. Yeah. He was just about to go on holiday to Scotland, and I said, well, you go and do that then, and then you can go and see the oncologist once you're back. No, we'll cancel that. We need to go and see. And I think it's quite a difficult mindset to change in them, that actually you're looking at a different situation now. But no, it's certainly for him and for other patients in this sort of situation, they don't feel that it's been a waste of time, because it's actually given them good quality life. He's been in, you know, had very good quality of life all of that time. He's recovered very well from all of his treatments. So he certainly wouldn't think that it had been wasted.
And objectively, his treatment's been a success. He's 7 years out of disease that 20 years ago would have killed him. Yeah. So, or whenever, you know, but he's 7 years out of having successful treatment for life-threatening disease. And there's every prospect that with or without further chemotherapy, he's going to live for another 5 years, I would say. So actually, his treatment's been a great success. And him going forward, you know, the oldest person I've treated with chemotherapy was 94, and they did extremely well, you know. But, you know, I don't do it every week. So I wouldn't say that he would never be able to have further chemotherapy. He's got chemotherapy-sensitive disease. If he looks like his disease is accelerating and he's running into trouble, and he's likely to become symptomatic, then absolutely I would, actually, even at 85, consider him for more treatment. But just now, it's a question of, you know, we're not going to get rid of the disease completely. Absolutely. It's how we manage it for his quality of life, probably over a period of years.
I think we mustn't underestimate time, because I think that's very, very, very important to all of these people. And I think many people now do fall into the mindset of this has gone from the big C to chronic disease, such as diabetes. And that's again evolved over the last few years. And it's all about, I think you were talking about get its functional status, etc. So right at the beginning, Ian, and I think that's important, because you then set the tone, and those conversations are so important right up front, because then you get to this situation and it's not the sort of here we go again, but it's okay, it's part of the disease, it's you're living with it.
There's a slight dichotomy, isn't there, in that, you know, if this man had prostate cancer diagnosed at 70, he would live with his disease, and yet, you know, we're emphasising here that it's treatment and failure. Perhaps we should be changing the emphasis about continuing in life with your disease, with episodes of treatment along the way.
And particularly for these people with relatively small volume lung disease, that is exactly the conversation I'm having with people now. Because, you know, there's something about them. I've got quite a big series of people now that they are living with their disease 5-10 years.
When I did my research into PET scanning, we were finding lots of incidental low volume lung disease that actually had very little impact on overall survival. And I think, you know, the harder you look, the more you'll find, the significance of which is we don't quite know yet.
But did you find their nature? What sort of lesions are these?
No, we didn't.
Okay.
I think living with the psychology of the doctors not doing anything is actually probably the hardest bit with my patient hat on, that a patient would much rather be taking something that, even if it has a very, very tiny chance of working, and this comes back to Myrddin's comment about hope, and, you know, moving hopefully, as opposed to feeling like nothing's being done. And I think that's where that sort of abrupt stop in, actually we're just stopping now, is really difficult for patients to cope with.
But in prostate cancer, it's the fact that we're surveying people and just keep them monitoring. You know, we could be offering him monitoring. Is there any role for sort of short pulses of chemotherapy in these patients?
Well, I'm not a great fan of treating people just because the need to do something rather than nothing. I think it's all about how you start off with the conversation, what their
managing the expectations from the outset.
So, you know, this chap will be on active surveillance. We have the opportunity to intervene at any stage. You know, he can take aspirin if he wants. I'm not sure at the age of 85 I'd be recommending him to do that, but he can go and see other, you know, nutritionists or whatever if he wants to be doing active things. In terms of oncological interventions, you know, we had to be very careful about not doing him harm. And it's just about, I think, the management of the timing of the interventions. Effectively, it would be, you know, if ever I was to treat him, I'd only treat him for a few small weeks at a time. And that can be a very effective way of doing it.
Yeah, but I think it's about managing those expectations, because I think we underestimate the harm that the psychology of doing nothing does to patients, potentially. I think certainly sort of, you know, with some of our...
Merv. Sorry. Another comment about, I agree with your comments about low-volume lung metastases. MD Anderson have produced some papers showing that for people with resectable liver mets and low-volume lung mets, a lot of oncologists will write them off, but actually they will benefit from clearing the liver.
Yeah, absolutely.
And they just live with their little lung mets.
Absolutely. Yeah.
And I think this is increasingly, you know, well recognised, but not by all. I think it's a very important point that he's just raised.
I think there's some evidence of patients who've had liver transplants as well for metastatic disease, and despite immunosuppression, their lung mets have not, a small group, but their lung mets have not progressed.
That came out of the Oslo series, that of the 30 patients, I think, a few of them developed lung mets on immune suppression that did not advance that quickly. Yeah. I mean, that was probably as staggering as anything, you're quite right. And that was presented last week at our August meeting, and you know, there's a lot we don't know still.
But it is this type of information in which actually will help you discussing with the patient.
Yes.
These studies are important to come to the public.
Okay, let's move things on. So the key learning point from that case was that aggressive management of metastatic disease can result in extended good quality life, even if cure is not ultimately achieved. So welcome back to the Iceni Centre, where we're going to discuss that fantastic lecture from Merv Rees and the MDT case as well. I've got with me Professor Tan ARULAMPALAM, who's going to discuss that with me. Welcome, Tan.
Hi there.
What did you think of Merv Rees's lecture?
It was absolutely knockout, wasn't it? So he talked about functional imaging, which is something that's very close to my heart, and I think we were talking about this just before we started. You know, it's very, very important to actually understand for the liver surgeon, you know, which bits of liver are functioning normally, where there is cancer. It was very interesting what came up in discussion subsequently about the use of PET scans, and it's not an absolute necessity at the moment. So that was very interesting for me. But there were some other points, weren't there?
Well, I mean, first of all, I'd like to talk about this molecular imaging, because it's just unbelievably good, isn't it? It's the holy grail. Transfer that to the cancer. If you could see the biology of the cancer before you started any sort of management, you could predict outcomes for the patient, you could select the best treatments for that particular cancer. It'd be amazing. And I think that just showed me, and as I was watching that, showed me how far we are along that road. We're starting to take little steps along that road, aren't we?
Well, you know, I think imaging now is you know, coming to the stage where it's a biomarker that we have to look at. And you know, if you fail to prepare to fail, and it's so crucial in these patients. And I think the other thing that's important, and Merv didn't refer to this, but we now have software algorithms looking at texture in these patients, and we're getting to a stage where we can run AI through this, and it can help us look at survival and look at disease progression, etc. So I think radiology, as you mentioned, is so crucial. You know, we ignore it at our peril, ignore the new techniques, absolutely.
Merv said that in the late 80s and 90s that the advent of CT and MRI was like allowing a blind man to see, and now we're further down the road from that. Yeah. The other thing that stood out was how so many cases now being referred to a liver centre have been converted from an inoperable stage on initial radiology to an operable stage by conversion chemotherapy, neoadjuvant chemotherapy. About 40% of their cases now are in that category, which I think is a real take-home message. And it also points to the fact that perhaps the primary centres are not referring as many patients with liver metastases, or even liver metastases with extra-hepatic disease, than they should be. Because certainly we've had 1 or 2 cases that we thought were utterly hopeless, asked an opinion, and they said, no, there's something we can do here.
Well, I think if you look at our speciality, colorectal cancer surgeons, what we do has changed immensely. And for the liver surgeons, we're a lot better than we were 10 years ago in terms of referrals. But it's not for a colorectal MDT to make the call on the liver decision. And I think the liver centres are keeping fabulous data, and they need the referrals. They make the call on what the hopeless case is. So I think that point is very clear. So, takeaway for me was make sure you refer your patients and don't make the call on the hopeless case. The worst that can happen is the liver centre will say, no, that really isn't there. And as you said, 40%, that's a huge number. That's a huge number.
Now that MDT case was very interesting, wasn't it? Looked like a metastatic case that could have treatment, and then went on to have further treatment with lung metastases, and subsequently, unfortunately, had further disease that was deemed palliative. But this was over a period of 5 years or so, and in that 5 years, that patient had really good quality life. And perhaps, cure as an ultimate aim in some patients isn't what we should be looking for. It's something else.
Well, we chase this as a holy grail. And the fallout of all our radical surgery it can be massive. But actually, in that patient and in many patients, I think there are quite a few French series of radical surgery for metastatic disease. The patients have time, they have good quality of life, and I think this is where the MDT discussions are so important. We really are making a difference to that group of patients.
Indeed. Okay, well, thank you for coming to talk to us. Another fascinating discussion. Thank you very much. So we've seen some fascinating things discussed during this episode, and hopefully that will stimulate some discussion and new ideas back in your hospital as to how to improve the care that rectal cancer patients receive locally. Remember, if you'd like to get in touch with the Iceni Centre through any of the routes shown here, then please do so to give your feedback, and we look forward to welcoming you next time. Goodbye.